everyone. Welcome to this episode of Science Speaks, an interview series from Sciencera that discusses a variety of topics about science and life in the world of science. I'm your host, Aram A. Kumar, and today we have with us Dr. Sanjay Mishra. We will discuss with him about where we are in the COVID-19 pandemic and what's next in the fight against SARS-CoV-2. Dr. Mishra is a staff scientist at the Vanderbilt University Medical Center and project coordinator of the COVID-19 and Cancer Consortium, an international group of over 125 cancer centers and other organizations who collect and study data about cancer patients with patients who have been diagnosed with COVID-19. His work and writings on COVID-19 have been featured by top scientific journals like The Lancet and Science, and by news outlets like Reuters, The Conversation, Fox News, and more. So welcome, Sanjay. Thank you so much for taking the time to chat with us. We really appreciate it. Before we dive into the topic, I was wondering, could you give us a quick overview of the work done by the COVID-19 and Cancer Consortium?
Thank you, Aram. I really appreciate your time, the chance to talk to you. So the consortium, and I would use the abbreviated CCC19, which is what we like. CCC19 is a consortium that I always joke that it's probably the only good thing that has come out of the Twitter in, say, 2020. We were formed by a quick tweet by a fellow and asking for a simple question that the cancer patients are especially vulnerable to the COVID-19. And from that question, the consortium was quickly put together, and we are collecting de-identified, manually curated data on adult patients with current or histological invasive solid or hematological malignancies who have been diagnosed with COVID-19 with or without a laboratory confirmation of the SARS-CoV-2 infection. This is one of those examples where the entire data collection has been voluntarily. We do not compensate anyone. And despite of that, 125 centers as of this date are participating. Like I said, across North and South America. We have partnered with European agencies, with the European Nodal Agency for the Cancer Scientists. And this is one of the biggest data collection of this type anywhere done.
Yeah, that's just incredible, and to think that all that started with the tweet. Just amazing, especially the size and this being completely voluntary. And so I wanted to ask, like these 125 centers and collaborating with them. So what has it been like to work in and coordinate such a massive collaborative effort?
Before I dwell more into it, the one thing I would say is that this has been an extremely humbling experience. I come from the training as pretty much fundamental sciences. Most of my work has been rather obtuse. Structural biology and biophysics do not necessarily translate in most people's lifetime into anything reasonable. But at the same time, this is an experience that I always compare, and I know this is a pretty cliched expression, but in certain sense, this has been as if we are building the plane while also flying, and some of the things we do, they are learned and changed mid-air. We did not. I would be lying to say that we were ambitious enough to imagine that in less than a year's time of our formation, we would have reached 125 or so centers across, like I said, North and South America. And the number of cases that we have would have gotten to nearly 7,000 at this morning. So it has been a complex exercise. There are lots of challenges that we did not know, logistical project management, in terms of the legal structures, legal frameworks. And in one sense, not knowing how complex it was could be called in itself a blessing. Because had I known all the complexities that are involved, I might have had serious doubt on my own ability to either put together or deliver on the certain things. But at the same time, it has been well peer reviewed. At this point, we have 3 peer reviewed publications, countless editorials. Some of them have upward of several hundred authors. So just making sure that everyone's name and addresses are correct and they have been entered correctly, that everyone's conflict of interest forms have been completed, and everyone had pitched in their ideas to the manuscript, and all those comments have been integrated is quite an accomplishment. But I think we have done pretty well, as reflected in the number of citations and the number of publications that we have already published and the number of manuscripts that are in the pipeline. So it has been well.
Yeah, thank you, Sanjay. That's a great overview, and I can't even begin to imagine. Like it could be quite the daunting experience. When I was in academia, and we had to get just forms and declarations done by 5 or 6 people. That itself was a mess. So I don't know what it would be like to do that for 100 people. As you said, of course, CCC 19 has been doing very well. The lots of citations, and there has been some great studies coming out of or results coming out of your data collection. So given your expertise in this area, I figured it would be a good start to kick this off by talking a little bit about how high-risk populations, like patients with cancer, right, for example, are affected by COVID-19 before we jump into the other topics. So people with cancer, and older patients, and people with other serious chronic medical conditions like diabetes or cardiovascular conditions, lung diseases. And we know that they are at higher risk for COVID-19 and worse outcomes. So, what are some factors that maybe underlying behind the high risk and worse outcomes that we see in these groups?
So what we know, so there are facts that we know, and there are facts we do not know. Yeah. What we have shown very unarguably is that the cancer patients who were infected with COVID-19, they died at a significantly higher rate. And when I say significantly, it could be 3 to 4 times higher than the global average. And while each number may or may not reflect correctly, but between the 2 studies that we published, that number has slightly gone higher. So the Lancet publication that we had in May 2020, that had the mortality at around 13%. The late publication that we had, it had slightly higher, 16%. This may or may not reflect the trend, and we are still looking into the newer trends coming up into the publication that should be in press probably soon. But what we do know is that the cancer patients are especially vulnerable to a disease, a pandemic as it is. There are lots of reasons. The cancer patients tend to be immunocompromised to begin with. They have special needs. Oftentimes, they also are elderly, and then they have more contact with the hospital system. Yeah. What is more worrisome is that we don't know how this will affect in the long run, because if patients are hesitating or the hospital system is not available for them in their early stage of diagnosis. So as I said, right now we are talking about the patients who have historical or either current or historical malignancies. What we do not know is what would happen with this disruption. Would this delay the diagnosis? So the patients who would have normally been screened, and we have had anecdotal evidences where certain patients were hospitalized for the COVID-19, and during their scans, it was found that they also had, say, lung cancer. Now, if these patients are being either denied the services or because the hospital system is overwhelmed, there would be delay in the follow-ups, there would be delay in diagnosis. How will that affect in the long run is something that we have absolutely no control on at this point. So that is why studies like this are especially valuable, not only to understand and be probably able to give some recommendation at this moment, but also to follow up them in the long run and to see whether the mortalities and the outcomes have significantly diverged from what the trends were, say, a year or 2 years back, and whether these numbers, the diagnosis, because right now we know that some of those supposedly avoidable cares are actually being delayed, and those delays might have a serious repercussion in the future.
Yeah, I think that's a probably unspoken toll of this pandemic, right? Where we of course know about, like you said, that the immunocompromised aspect of cancer patients, or say patients that are elderly or diabetes or other complications, and them being at high risk. But then there is this aspect of these are people who have chronic health issues that probably need continuous care and screening. And like you said, a lot of them, it is recommended too, right? Like that if you don't need to go, if it's avoidable, just don't go to the hospital. And but then that comes at a price, and we sounds like we don't know what that toll is going to be, but the data collection probably over time will tell us, what those excess trends are going to be. Is that okay?
Yeah.
Thank you, Sanjay. And let me ask you this: are there, we have general recommendations from say CDC or the WHO and so on, right? So are there any other special precautions that cancer patients would need to take in addition to stuff that is recommended by public health experts, like say social distancing and mask wearing and so on?
I am not in the game of recommendation, and I don't think that we have the granularity to actually be able to make any recommendations, so to speak. I think that is something that, unfortunately, as it happens, some of those recommendations they require more confidence in the data. But the one thing we know for sure is that there is no direct correlation between hospital visits and the outcomes in terms of the cancer and COVID-19. So the patients who have the ability and those who have been recommended, they should not voluntarily be avoiding hospitals. I think those recommendations and those decisions have to be made by their oncologists and have to be made by their physicians. That is very important. Patients should have confidence in the medical science, and the decision should be made by the hospitals. At the same time, if the hospital system itself is overwhelmed, then in some cases that decision is being made rather ad hoc and not necessarily driven by any clear-cut guidelines. Right. And unfortunately, those are the fallouts of a pandemic as severe and as uncontrolled as the COVID-19 is. Then there are a little disturbing trends, and that are primarily because cancer patients themselves are considered severe. So there is a possibility, and there is some evidence to it, that the treatments that are being tried, they may be what you can call a kitchen sink approach. There is a dire need to save them. So some of the medications that have come up, they are not always driven by robust science, and we don't have to go on to the history of it, but hydroxychloroquine was one of those examples. It was not driven by any scientific merit, but more by hearsay. And in those approaches, which are knee-jerk responses, patients which are already vulnerable, such as cancer, the outcomes can be severely worse than for the normal population or somewhat healthier population, or even if they are hospitalized, the outcomes that we see, they are very, very different from what other general population would have had.
Yeah, I think that's a great point, Sanjay, because yeah, it's if it's a healthy person taking a drug that doesn't work, it might not cause them major harm, but somebody who is already immunocompromised and like you said, have severe health issues, like certain patients with cancer receiving a drug that does not have any major evidence of working, of course, yeah, it will cause problems. Yeah, definitely a great point there. So I wanted to, follow up on this aspect of the specific risk or needs for cancer patients who may develop a COVID infection based on. So your group published an article in Cancer Discovery in October that showed that like you said, hydroxychloroquine does not have any benefit, right? Other than that, and hydroxychloroquine study after study has shown that it does not have a benefit. Yeah. But what was interesting to me from your paper was it also said it looked like corticosteroids in terms of all-cause mortality in cancer patients who had developed COVID-19 did not have a benefit. But like corticosteroids, for example, with the large Oxford University-run recovery trial, and some other studies showed a substantial benefit for patients who are otherwise, who develop very severe COVID-19 infection. Like it was shown that corticosteroids would benefit those patients. So I'm wondering, like it looks like the care of cancer patients who develop COVID-19 infections and others, like other patients who are probably generally healthy or does not have other comorbidities, this could be different. So what are some key considerations, in that aspect, given this example?
So since you're bringing up dexamethasone, I think this is one of those classic examples where evidence is what should drive our decision making. As you said, it is true that we have seen that the outcome for the use of dexamethasone has been very different, somewhat different from what has been seen or has been recommended by general public. But then you ask, why is that? While we don't have definite answers for that, but we suspect it could be, again, because cancer is already an immunocompromised state, and the benefit of dexamethasone might be coming from somewhat of immunomodulation effect. We do know that some of the worst outcomes of the COVID-19 come from something like, say, cytokine storm or very high autoimmune kind of symptoms. So it is possible that steroids probably could make potentially these things much worse in the case of cancer patients. So again, what we have is the data. We have the guidance somewhat that when healthcare practitioners making those choices, they should look into the data that either we have or other published sources have. What works for one population may not always work for the other population. And I think this is where the other example that comes, that two big studies, the study in the United States from the NIAID, their trial suggests that the remdesivir has some degree of benefit, whereas WHO's big data set and the recovery trial, that does not recommend any of them. It does not recommend remdesivir, hydroxychloroquine, and interferon regimens, and all of them, because they don't think that there is a survival benefit in the between the control group and the non-control group. Dual cohort, and you have to look at what works for one may or may not work as it is for the other.
Right.
But at the same time, unfortunately, science requires evidence, and science requires a little more patience than an advice which is not based on the evidence. So we are still pursuing on, and we are still following up, and we will probably try to understand. Ours is a retrospective study, so we do not have the study of we do not have the benefit of the clear-cut trials. So we have to believe on what the data is, more on real life situation, and in that real life situation, dexamethasone does not seem to have the kind of benefit that has been promised for non-cancer patients.
Yeah, I think great points there, Sanjay. So thank you. I want to so this that also sort of brings up one of my favorite points about how here public is seeing science unravel in real time, right? Like it's happening in front of their eyes, and so that typically you have over time, several years, evidence gathered that is going one way or the other, right? And in this case, they're seeing it right now because of urgency. So I want to now change gears a little bit. So with the colder weather forcing people indoors, and with many of us being exhausted by the overall toll of the pandemic, right? Like be it health or economic or social or psychological, right? And so many public health experts like Dr. Fauci are warning us that we are headed for a very dark winter. However, with cases increasing, death toll going up, but looks like hope is also on the horizon, with multiple vaccines already receiving or about to receive authorization for use across the world. And it also looks like, from the beginning of the pandemic, it looks like physicians have also, based on these scientific evidence and recommendations, as you mentioned, have learned to manage COVID-19 cases better as well. So we have clearly come a long way from the beginning of the pandemic, right? So I was wondering, can you talk about some of the therapies that have been shown to be effective? I know we mentioned remdesivir, right? Like mixed a little bit of, we have seen evidence in cohorts here, but then in the WHO study, not so much. Corticosteroids, dexamethasone, like you said. I'm wondering, what about antibodies? I know there are some that are already submitted for emergency use authorization with the FDA. And I know Vanderbilt has been very active in this space as well. So what role do you think, we can go to vaccines in a minute, but before that, what role do you think they will play in getting this pandemic under control?
So there are several things that you brought, and they each has to be elaborated independently. The overall mortality in terms of the percentage seems to have gone down, and that is most likely because the medical community had learned lessons and has somewhat of a more experience on handling the crisis.
Yeah.
But at the same time, oftentimes percentage is actually a belying factor. We have to also look at the overall number of burden that we have right now. It is a fact that now there are far more people who have been infected than they were earlier in the pandemic. So every subsequent wave has become bigger and bigger. So if you look at that way, the number of deaths now on a daily basis, they are far bigger than what they were reported at any stage in the past. And that is true for a lot of the places, but more so in the United States. So in that sense, I think we have to be very careful in making assertions whether learning that to handle the crisis has helped overall in terms of mitigating the crisis. And I don't think we are doing much better job in that sense. And I think, as you mentioned, the pandemic fatigue by itself and policy paralysis added with that, and then the economic consequences of this year-long pandemic now, all of that is making this overall containment of the disease really, really difficult. As far as I'm aware of, there is no approved medication to this date.
Right.
There are recommendations, and each of them has only a marginal effect. So remdesivir is one example, the corticosteroids are example, the antibody cocktails that have been around there, the convalescent plasma, and now the vaccine. All of them are a small increment towards having a better handle on the disease, but neither of them are, I hate to use that terminology, but neither of them are silver bullets to treat the disease. So the only thing that can help us to probably what has been often repeated is flattening the curve, is the common sense approach. Until we can find out a method which makes you recover in that sense, or until we can find a situation which is easy to reverse, I think the social distancing, avoidance, and those kind of approaches are going to be the only approaches that will work. The other things are helpful once you have been hospitalized. They can be help to stabilize you. But ultimately, it is your body which has to fight it out, because at this point, there is nothing else that is out there. Whatever we have is mostly symptomatic borderline, and each one of them can be questioned whether they are as effective as because you have to remember that some of the authorizations, they are also emergency authorization. None of these tools have been actually licensed or approved in the classical structure. Yeah. So whether they are effective, and if they are effective, then they are effective in doing what is still debated. So I would be a little careful in making assertions that we have any handle on controlling these things at the root level. What we have is a protocol that helps us to help and stabilize patients when they have been infected. But other than that, the disease is still taking its own progression, and overall numbers, they are now far bigger today than they were at this time 6 months or 9 months back.
Yeah, and I think, like you brought up, cases and the hospitalizations are higher than at any stage in the pandemic, and especially in the US. So of course that will, even if we are or the medical professionals themselves are better, handling this better, or have learned and have more guidance in how to handle it, there are only a limited number of beds and capacity that you can stretch only so much. So yeah, great points about this. Unfortunately, we haven't really found a silver bullet or flattened the curve either. Like I said, I'm hopeful in this case that the vaccines that we have as looks like they have shown good efficacy, and so I want to talk to you about the vaccines themselves, especially given you have written multiple articles on this topic that were covered by several big outlets. So I think you'd be a good person to ask some of these questions regarding the vaccines themselves. As we know, a vaccine from Pfizer has already been, again, I wouldn't say approved, but for emergency use only. And the other one from Moderna is expected to receive emergency use authorization anytime now. So both of these are mRNA vaccines, which, an entirely new technology for vaccine development. So can you tell us how mRNA vaccines work?
So the mRNA vaccines are definitely a very promising technology in the sense that they actually provide us what has always been called as a platform against a disease X. The pandemics are not new. Within this millennium, this is the third one. We already survived somewhat of the scares from the first SARS epidemic, and then the MERS, the Middle East respiratory syndrome. So this is the third one that has caused by the coronavirus. So the increased global travel, the climate change, and loss of habitat, all of them mean that the pandemics are here to stay. The last two ones, I think the lessons learned from last two X, the pandemics, helped us to fast track and understand how can we have a reutilizable technology which can be very easily scaled up and can be redesigned for whatever virus or whatever other disease X, which has been a WHO's placeholder, can work. So how mRNA vaccines work? Traditionally, the vaccines have been designed either by using attenuated or the weakened virus, or by taking part of the protein which is on the virus, which causes the disease, called antigens by the science. Those antigens, either you can prepare them from the virus, as in case of, say, flu vaccines, or in the case you can make them from outside. And by making them artificially, and then you add them into certain things, and then you give them to the body as a primer. So the body learns how that virus looks like, or how that the disease-causing virus looks like, and then get the antibodies made against this, build the immunity. So when you are infected in real life, your body already knows how to handle it. What mRNA vaccines do is that instead of making that protein or making that virus is a tedious process, and oftentimes it is fraught with a lot of uncertainties. As you can imagine, making a weakened virus is very good as vaccines go, but it is risky because you never know whether your virus can revert back to be active again. So that's always risky, especially for the people who are somewhat of a weaker immunity, like older people and the children and pregnant women. Making vaccines from protein is safe, but then the difficulty there is that making a good amount of protein and a good quality medical grade protein is an extremely long-term process, and it requires, and sometimes you don't know if your protein will work as good or whether it will be of the same kind as the nature has designed in an actual virus. So what mRNA vaccines do is that you take that instruction and give that instruction to the body so it can make its own protein. And mRNA by itself is a very short-lived thing. So it goes into the body, and current evidence suggests that within a week or so, the mRNA itself dies out. But during that process, it does make the protein in the body. And there's enough within that week or so to then start the immune learning process. And the hope is that by doing so, there is enough of that response that then the body can learn and can make good antibodies and good immunity of its own in the long run. Now, this was an ambitious technology, and it has taken quite some time to get perfected for the simple reason, like I said, the RNA itself is very unstable. And then how do you deliver it? Because a lot of the viruses, they are based on RNA. RNA viruses are one of the largest class of viruses. So the body's natural defense system had worked to actually destroy the RNA as it existed in the nature. So the scientists have to figure out a way how you can stabilize the RNA. How do you make it to then dodge the body's natural defense system, the toll type receptors? And then after that, how do you deliver them correctly? So there were lots of hurdles, but it is very encouraging, and it's extremely satisfying to see that after several decades of work, the technology has matured out enough that now it is ready to be, it has already passed the phase 3 trials. The emergency authorizations has been forthcoming for the Pfizer vaccine, and Moderna is quite on the line, and most likely within this week it will be there. And there are several more candidates. There are other candidates who promise to have a better temperature tolerance, like CureVac from Germany. It they claim that this would be available to be delivered even at the room temperature, so it may not require that kind of a ultra cold temperature. So it is a promising technology, and we will have to see whether the efficacy that has been seen in the somewhat of a controlled group, somewhat of a restricted age group, will hold its promise in the real life.
Gotcha. Okay. Yeah. Thank you for going into that detail and really explaining the intricacies of mRNA vaccine development. And as you noted, of course, it looks like we came up with this, or scientists suddenly developed a brand new technology. But as you said, the groundwork has been laid decades ago, and we are building on it, and it's very exciting to see it come to fruition. So you did mention the other more traditional setup of making proteins that are that could be effective as vaccines, but then of course comes with the challenge that it would be difficult to produce and produce good quality proteins that can act as vaccines. So as I understand, there is a third vaccine that is pretty far advanced in terms of the clinical trials, and probably a good chance of approval. So the one from Oxford University and AstraZeneca looks like that it fits that more traditional mold, and the temperature factor, like you said, Pfizer and Moderna vaccines need to be kept at really cold temperatures, and this one can be more normal temperatures. So it looks like it's a little less effective, but can you tell us, in terms of delivery and capacity and all these storage and these factors, what role this vaccine can play in our fight against COVID-19 as well?
Yeah, so the AstraZeneca vaccine, that is also a very exciting new class of vaccine. And it is actually, while it is analogous to the traditional approaches, it is not traditional at all. In fact, if it makes to the approval process, it will be the very first of its own kind. So how does that work is that it's a chimpanzee cold virus, which has been designed or modified not to be able to grow. So remember, this is a chimpanzee virus, which means that it does not affect humans as it is, because viruses have their own specific host requirement. And on top of it, it has been modified to not grow in the natural system. So it grows only in the test tube, but it does not grow into the body. It is replication deficient. And then most of its genome has been removed other than what is needed for it to pack as a virus. So it can, and then you take an external protein, in this case, the spike protein of the SARS-CoV-2. And then when you design it into this virus, the chimpanzee adenovirus then behaves as if it's SARS-CoV-2, in the sense that the spike protein then coats it on the surface. And that's what you're giving it. So it's an extremely ambitious kind of a vaccine. It is a very new vaccine, very similar to the mRNA vaccine, in the sense that it's a platform which is now seeing its first day in the real life. As far as the efficacy is concerned, I don't want to get too hung up on it. It is very difficult to compare apples to oranges. And we also have to remember that the benchmark that was set for the COVID vaccines, their expectation was 50% at the peak. Yeah. And they could have been even lower than 50%, because at this point, when we have a pandemic wave, what we want, the first thing is, again, going back to the classic flattening the curve, we want to slow down the progression of the virus. And if we can slow it down sufficiently, we can we can slow down the progression enough that we can buy some time. There are 42 vaccines in the advanced stage of development, and there are several hundred in the pipeline. So if we can buy some time, we can then either develop toolkits. Maybe there are some medicines that can come along. Maybe there are some antibiotics that can help us better. So we shouldn't be getting too fixated on the numeric difference between the efficacy of, say, Moderna vaccine versus Pfizer vaccine versus AstraZeneca vaccine. And then There are some that are coming from Johnson and Johnson and Sanofi. They all are very exciting technologies, and they tell that given enough resources and money, and also with enough excitement in the scientific community, we can win these things. It's reasonably efficient. There is some doubts on the numbers that have been put forth, but at the same time, the data is now available into a peer-reviewed journal. And when I read those numbers, they look very promising. There are some questions that they need to answer, and I think they are still in the testing phase. But the hope is that if those numbers, as they have been published, they hold correctly in the more extended trials, it is a very promising vaccine. And like you mentioned, because it does not require that extreme storage requirement, it definitely has a very good promise, especially in those circumstances where these cold chains are difficult to maintain, or if we need these vaccines, because we don't know at this point any of these vaccines, because it's been such a short time, we don't know what the duration of the immunity is. So if we need multiple immunizations, I think the question of what is available to which age group and which population group and which region, I think a lot of these candidates will all come handy in that time.
That's, yeah, I think, really good point about not getting hung up on the efficacy, and especially given where we started based on our expectations was, that 50% cutoff. And now we have these different candidates all, really blowing those expectations out of the water, at least in very, very controlled trials. So if that can hold, that would be really amazing. And it also looks like both the Moderna and Pfizer ones are a lot of these initial doses are going towards more Western countries, and while the AstraZeneca Oxford vaccine looks like it will also be going to other places that need the vaccine as well, like India, right? So I guess we need all the help we can get.
And even in that class, the approach that the CureVac is using is very interesting. One that they claim, of course, they are still in the phase 3 and has been tested only in Germany, but it claims to have 3 months of stability at the normal cold refrigerator, just the grocery style or deli style refrigeration. So that even if the mRNA vaccines are the way to go, that one will have a pretty good chance of being available even in the low resource places. And then they are trying to be in collaboration with Tesla. So instead of having this large cold chain, you have to remember that one of the advantage of the mRNA is that it's rather easy to produce. It's more of an industrial product than a biological product. So what they are trying to do is that they are trying to have these mRNA microfactories. And the hope is that with those small microfactories, you can actually produce them somewhat closer to the end user. And then with this very efficient stability of about 5 degrees Celsius or about 41 degree Fahrenheit above zero, you can store it well, you can produce it locally, and you should be able to distribute it to even the resource limited regions. So I think the hope is on the horizon. One thing I want to highlight is that I think in one sense, and it's very morbid to put it that way, but we seem to have hit the jackpot in terms of the antigen selection. A lot of the vaccines fail because vaccine is not something you develop on the textbook. You hope that your antigen selection, like in this case, the spike protein, would be the one where a lot of the success will rely on. What is really encouraging is that all of these vaccines have focused on the spike protein as the primary antigen, and they all have shown extremely good efficacy. Like I said, we don't know the duration yet, but we hope that the duration would also be good. But even if it's not, in terms of the efficacy, they are all very good, very efficacious vaccines. So I think because of all these candidates, I'm sure there would be candidates which will be suited for different environments, different affordability, and different regions. So they all should do pretty good.
I think that's definitely important because we have been trying to build the vaccine for HIV for
That is correct. Yes.
yeah.
And also Zika. I mean, the ADE has always been suspected to be one of the problem. Nothing that has come out from all these trials suggests that we have to worry about that. And so in that sense, you really don't know early on. You don't know whether any of those risks will pan out. So
we already talked a little bit about how these vaccine candidates that we have seen are really effective, but I wanted to touch on safety for a moment, right? Because that's a concern for a lot of people. So I want to talk about like how does the safety profile of these candidates look like from compared to say historically what we have seen with approved vaccines?
None of the vaccines that are, and they have been tested. If you take the overall class of the vaccine, not one, but in entirety, the number of people who have been tested with these vaccine candidates is very, very large. I think in that sense, it is unprecedented. Never before vaccines have been tested on that large number of people before they were released. Nothing so far that has come up should worry anyone that there is a risk. All vaccines have some inherent risks, and more so for these vaccines, which are entirely new class of vaccines.
Right.
I think the vaccines have proven reasonably safe given what we didn't know about these vaccines. There have been some discomfort, but most of those discomforts have disappeared on their own, and no one or very few of the volunteers had needed a hospitalization because of the vaccine. So there are recommendations because they are untested. Unfortunately, the current guidelines is that if you have a previous history of allergic responses, if you have previous history of anaphylactic responses, if you are overtly sensitive or if you are overtly allergic, you should not be given those vaccines. So those will remain in place until we understand more about it. But in the last 1 week of them being available in the real life in UK and now in America, in the real life, and even in the during the phase 3 and phase 2 and phase 1 trials, there has nothing come out that should worry anyone. I think they are very safe vaccines. And between your alternate, given that this pandemic has such a high effect on people's life, I think no one should be worrying about the overall safety of the vaccines.
Right. Yeah. I mean, yeah, I saw that there are, so far, 3 reports of severe allergic reactions, but like you said, in real world, it has been administered to probably thousands of people at this point. And
and I would not call them severe allergies. What they have is that they had allergic responses, but none of, to my knowledge, had required hospitalization.
I see. So that brings me to another interesting point. There of course vaccine hesitancy or the anti-vaccine movement has been around for a while now, and there have been a lot of misinformation that already has caused people to have some sort of hesitancy about getting vaccinated. So here, specifically because this is a new class of vaccines, there have been their own specific, for the lack of a better word, I would say disinformation campaigns running around that I have seen, both being shared profusely online or as talked to word of mouth from people. So I want to touch on a couple of those real quick. One of them is vaccines. This being an RNA vaccine can cause change in the DNA of the recipient, or the other one being the COVID-19 vaccines can potentially cause female fertility issues. I was wondering, if you can maybe take a minute or two to quickly dispel these misconceptions.
Yeah, the hesitancy against vaccines is not new. They have existed ever since the vaccine came along, going back all the way to Ben Franklin, who decided not to vaccinate his son, and then he passed away, and he regretted it. So it is not a new thing. It is a standard feature of our society. If I look at the flu vaccination, the vaccination coverage has never reached to the 50% of the population. So we have to be cognizant of the fact that people are hesitant to vaccines, not justifiably, but at the same time, we don't make the society. We live in the society that we have. We can convince people that these vaccines are safe. A lot of their questions need to be heard and they need to be answered. So the two that you brought, I think both of those are only the tip of the iceberg. People have had multiple questions, and I would like to have a forum. All of us should be actually pitching into asking and listening, asking questions and listening to the concerns that they have. So the fact that the mRNA is can be somehow can modify somehow the DNA, I think people should allay their fears. mRNA is like a Snapchat message. It does not stay for a long time. It does what it does, and then it goes away. In fact, that was the challenge that these vaccines have faced for almost a decade. It was very difficult to make the RNA even last long enough to be able to do something. Mm-hmm. So you can't have something which is so fragile that it needs extremely cold temperature to survive, then also be able to do long-term changes. The mRNA has no ability to convert back into the DNA. There are no tools for that. It is injected and it stays into cytoplasm, and it cannot have a mechanism. There is no signal for it to carry from cytoplasm inside to the nucleus where your chromosomal DNA sits. So one, it cannot go there. It cannot do a change. There are no natural tools available for this mRNA to be converted into DNA, except for those rare circumstances, if possible, for somebody who has a persistent retroviral infection, such as, say, an HIV. And even if that were to happen, the DNA itself does not get integrated. In those cases, it requires support of other tools, which are just not existent in the mRNA vaccine. So the mRNA either by itself doing a change or being converting into DNA and then causing a gene modification is just work of a fiction, and there is no science behind it. In fact, some scientists would like to have those efficient tools to be able to do gene changes, because then probably you can use some of these tools to make changes in the cancer cells. Right. Unfortunately, it is not possible, and that is why treating cancer has been so difficult, because we don't have the correct tools. In fact, the mRNA vaccines were first being developed exclusively to mitigate cancers and to be a cancer therapy, and it has been long that we don't have the correct methods and correct tools to do those long-term changes. So I think people should not be worrying so much about that. I've heard the stories about the syncytin 1, and that somehow that little homology of 8 to 10 base amino acids that exists between syncytin and the spike protein. The reality is that most people who understand these things would realize that that small homology exists between any two unrelated protein. So the idea that somehow that little stretch of spike protein has small homology, it's not identical, it's a good homology, but not a lot of homology, would have any effect on the behavior of the syncytin protein or syncytin 1 is just not correct. Because if that be the case, in these large number of patients which have been tested, and those patients who have suffered, we would have seen a significantly high amount of effect, which is not what we have seen. Now, when you have an infection, a natural infection, yes, oftentimes the pregnancy is suspect in those cases, and the first term pregnancy and the losses are pretty high. But it's a correlation and not a causation. So the idea that somehow giving an mRNA vaccine which has a small degree of homology with the protein in the fetal development or in the in uterus will have any effect is just not correct. So I think people should allay their fears. They should trust the medical community, and they should trust the public policy developers and go from there.
Thank you. And I think from what I have seen for regarding specific, COVID-19 infections in say pregnant women, there simply hasn't been any level of concern there, or a matter of causing miscarriages or causing problems to pregnancy so far. Like even in case of real COVID-19 infections, it hasn't
They,
happened. So
they are
like,
not significantly higher than other infections. Most
right.
infections make gestation difficult to begin with. So it is not surprising, but it is not, the risks are not significantly and higher than, and the data does not exist to support any such fears.
Okay, thank you, Sanjay. And so, I also want to take a few minutes and quickly talk about, what lies ahead, right? And what percentage of the population needs to get vaccinated for us to, say, achieve herd immunity, right? Or, to reach a point where we have the pandemic under control?
The estimates are little difficult to make. The general, the rule of thumb had been somewhere around 60%. The problem with that is that we don't quite know exactly what the R naught is, so we don't know exactly how many people each infected person actually reinfects. So it is difficult to actually put a magic figure on that, but I think it can be safely assumed that if we could get even to the level of the flu vaccine level, which is nearly 50% to the 60% of the coverage, I think that would be very effective. It is difficult to know ahead of the time what would be the availability of the vaccine. We don't know what the compliance would be, and also we don't know what the durability would be, how frequently.
Yeah.
One of the somewhat of a concerning has been that most of the vaccines that we have, at least on the leading edge of the approvals, they all require dual doses. Not to say that the one dose is not sufficient. They still have a very good efficacy even at the one dose, but they have been tested and they have been recommended at the 2-dose level. Compliance of those 2 doses would be a little difficult. So it is hard to imagine what would be overall acceptability of the vaccine once they are available, and when they are available for general public, how many people would actually be willing to take them. But I think at least 1-dose regimen of a lot of these vaccines, if we can achieve somewhat at 50 to 60% level, that would be really, really recommended. And that would be a safe point to then imagine that we would have recovered ourselves from this pandemic safely.
Yeah, I guess that goes on to tell us, emphasizes the importance of not being complacent just because, there are some good vaccine candidates here. In that case, I would think, we would be maintaining these, a lot of these current public health practices that we are using to tackle the pandemic, like social distancing and mask wearing and avoiding crowds. Okay. The other, I guess, a little bit of a futuristic question in this case is these mRNA vaccines, like you said, they would be the first of their kind and to be approved. So they have been quite the accomplishment in vaccine research itself, right? So if they are successful in this larger population, once we are administering them worldwide, do you anticipate this this technology to sort of revolutionize vaccine development and targeting other diseases using this technology?
Yeah, no doubts about it. I mean, we have achieved so much in such a short time, primarily because so much legwork was already done. The relative efficiency, the relative quickness by which these vaccines have come along should not fool anyone, because we had already almost gotten our foot to the door when the last crisis has come. The spike protein, especially the Moderna's candidate, was almost the same structure and same design which was already done forth by the Morse candidate in the NIH. So it is not like that these things have just come out of the hat. They were there. The platforms were already developed. A lot was learned from the last two pandemics, so we could make it that move very quickly as possible. So as far as the platform goes, I think these technologies have now reached their maturity. They are what would happen from this round is that we will have not only seen their benefit in the real life, but we would have evolved and developed the structures which support that kind of a thing. But then whether this would be a silver bullet again, it is very difficult. Biologists don't have a crystal ball. What the next pandemic will come would bring its own challenges. It is possible that a next pandemic could be much less severe and would not be as infectious. Maybe we would have learned our lessons and how to contain it at the point of its origin or then from spreading. Maybe we would have begun to have better trust on the public health officials. So when we are told to stay put and not be out there spreading the disease during the Thanksgiving and the Labor holidays and the Christmas holiday, I think that would have helped us a lot. Maybe we can stop damaging the environment, which then causes sometime these human-animal interactions to be far more. I think that is something that has to be also. So it is difficult to imagine what the next challenge would come. I think each pandemic has its own survival curve. What causes one would not necessarily be the one that will happen the second time. But it is true that these vaccines have definitely come to maturity. And I think what we will learn from here will be useful, exceptionally useful for the next experiences. And especially the mRNA vaccine, they have enormous advantage. They are very easy to tailor made for whatever comes along. They are agnostic to practically everything else. And there is a hope that some of the safety parameters that we are seeing would be agnostic to each one of them, because it is possible that some of the side effects that we are seeing or some of the reactogenicity that we have is for the lipid base and the lipid nanoparticle. If that be the case, then it would not matter whatever vaccine it is, because all we need to do is we change the mRNA and it would have exact same efficacy and it would have exact same safety profile. At the same time, I want to re-emphasize, we seem to have hit the antigen jackpot. So whether we will be able to replicate this success next time, nobody knows. But especially for other ancillary benefit, I think they do open a gate of a lot of promises and success going forward.
That's great, Sanjay. Really appreciate you answering all these questions, and we have covered quite a few topics today, and so has been an excellent discussion. So I really appreciate you taking the time today to share your insights with us and providing us a ton of really useful information. So thank you very much, Sanjay, on behalf of ScienceEra and myself and our audience. We really appreciate your time.
Thank you. I really appreciate it. Thanks for the chance.